providers, campaigners, individuals with their own lived experience, professionals working in the field, and also people who are family members and carers for people with mental health problems. So we're delighted, and a big thank you to our funders for helping us with this work. And our funders are the Open Society Foundation and the European Commission. And Christine is here from Open Society Foundation if you want to find out some more about her organisation as well. So I'm going to hand over now to Julie Beadle-Brown, who led the research for this, and Julie will take us through some of the main points of the report. So over to you, Julie.
Okay, thank you very much indeed. Okay, so as Nigel says, my name is Julie Beadle-Brown, and I work along with Agnes Turnpenny, who's here today, and our colleague Gabor Petrie. I work at a place called the Tizard Centre at the University of Kent, over in Canterbury in the UK. And the Tizard Centre is a relatively small group of academic staff, but many of whom also have a lot of experience in the field. So we bring together people who are psychologists, including clinical psychologists, through to speech and language therapists, through to people from social work, social policy backgrounds, and a whole range of people. And unlike most university departments, we are a little bit unusual in that we have a mission statement, and our mission is to reduce exclusion and to improve quality of life through the promotion of better services. And services, I mean, a very wide definition of services. And so that is the context in which we do a lot of our work. So I'll tell you a little bit about the project, but before going into some of the details, I wanted to just kind of point out that this was a very collaborative project. The project was done very much in partnership with Mental Health Europe, and also involved a lot of other stakeholders, most importantly people with lived experience of mental health problems. Sometimes we use users and survivors of the mental health kind of system. They were involved not just as participants and sharing their stories, if you like, and their experiences, but also very much as in terms of advising and on the advisory board of the project. So they were very heavily involved also in things like writing the reports and helping with many aspects of the project. Okay, and obviously we're very grateful for the work that they've done. As part of the project, we collated data in 36 countries. I think it's 37 if you separate Scotland and England, but we'll go with the UK for now. So 36 countries. And more than 60 organisations and hundreds of individuals were involved in providing the data that you see in the reports that you have available. And we're especially grateful to we actually had 28 people with lived experience who from across 14 different countries who provided their personal testimonies. And of course, that was quite different from the previous report in 2012. And what it allowed us to get was very much not just the numbers, but the impact, to work with individuals to find out what has been the impact for them of being in institutions, and in many cases experiencing forced treatment, so being made to live in an institution and to have treatment against their will. Although collating data across many countries is actually a really challenging exercise, partly because there is very little data actually gathered in different countries about the situation of people. It goes not just people with mental health, but it's an issue across all kind of disability groups as well. However, we were able to pull together information that showed us that there are still many people with mental health problems who live in institutional settings. And in almost, and many people living in kind of psychiatric hospitals and other what we call social care kind of institutions. I'll come back to those in a second. In almost all countries, psychiatric hospitals coexisted with general hospitals. So in most countries there were both kind of specific psychiatric hospitals, and then general hospitals where people would be admitted, for example, for treatment. And the balance between those two varied across country. So, for example, in most countries, the majority of beds, if you like, for people with mental health conditions are in general hospitals. But in some countries, there were some countries where still the primary provider of support or care in this situation were psychiatric hospitals, and some of these were very big, up to 1,000 people in each hospital, in each psychiatric hospital. What we call social care institutions were prevalent across Europe. And these are generally large congregate settings, often very isolated from society. They are what we often think of as an institution. And they generally aren't providing much in the way of psychiatric help. They're a place for people to live in the absence generally of any support to live in the community. So when community-based services, when there's no support for people to actually live in the community, these are one of the few options that people have. And people generally live in these places indefinitely. They're not a short stay place. They go in because there's nowhere else. There's no other support for them, basically. And actually the majority of countries still reported social care institutions that were where people with mental health problems were living. Such settings were the main form of support provided in Eastern European countries, but still exist in Western European countries. And in Western European countries, they usually exist alongside community-based alternatives, so there's usually both systems running. And in some countries, these institutions aren't just for people with mental health conditions, they provide support for mixed groups. So you have people with mental health problems mixed in with people with an intellectual disability, elderly people, for example. And often, in some countries, they're both children and adults mixed as well. And you know, that's still the case happening in many countries today. As I said, community-based services exist alongside institutional services in almost all countries. Although in some countries these don't have any formal support, they're provided by NGOs who kind of, if you like, have set them up, but without any, for example, government funding or any other kind of support. And the nature of these services vary across countries, but where they exist, they aim to help people to remain in the community even at a time of crisis. That's the aim. They should be good enough that people can stay in their own home rather than having to go into psychiatric institutions. Okay. Now the reality of that, of course, varies across country, how well they do that. But that's usually the aim of community-based services for people with mental health. Although there's been improvements since 2012 with, for example, new policy and standards, in some countries, full guardianship and substitute decision making still exist in almost every country that we worked with. There was only a very small number of countries where full guardianship wasn't a kind of a feature for people with mental health conditions. Of course, the numbers vary by country, and sometimes it's very difficult to distinguish. The figures on guardianship do not allow us to distinguish the conditions, if you like, so whether they're for people with mental health, whether they're for people with dementia, whether they're for people with intellectual disabilities, for example. But we know that there are still substantial numbers of people with mental health conditions. Okay. Really, since 2012, since the last report, there's been very few changes in reality. People are still living and being sent to institutions, sometimes spending quite a long time in psychiatric hospitals. People are still experiencing forced admission and forced treatment. Forced admission often equals forced treatment in most countries. There has been quite a few plans and projects, and there is a bit more infrastructure, if you like. There's funding from the EU. But one of the issues that we find is that actually there's very little evaluation of programs, and sometimes we don't know really where the money's being spent. And often when the work around closing institutions and getting people into the community, people with mental health problems are left, they're kind of at the back of the queue, if they're involved at all. And that has kind of been one of the issues. And then the final kind of barrier and issue has been the issue of austerity. Since 2012, that came out as a big issue in almost all countries. But it was particularly important in countries where there already was a community-based system. So it was most likely to affect the services available in the community and put people back, if you like, in kind of the institutional pathway. So that was the result of austerity. And then finally, to finish on a kind of positive note in terms of one of the things, and I mentioned it a little bit at the beginning, one welcome change, I think, from 2012 appears to be the increase in the strength of the voice of people with mental health problems within the system, and the evidence of people with lived experience being more influential in a number of countries, and in that case, it's not true everywhere, but it seems to have been, it's more obvious than it was in kind of 2012. And of course, the project itself, working has demonstrated the importance and, if you like, the immense value of working collaboratively with people with lived experience, and how that has brought a kind of a richness and usefulness of the data that doesn't come from simply looking at figures and numbers if you don't get those lived experiences. Okay, thank you.
Thank you, Julie. So I'm just going to talk for a short period about from a Mental Health Europe perspective. So I think, first of all, we're very pleased at the turnout and the people who are here, and I hope that you can help put forward a message out there to the public about some of the difficulties and challenges that there are for people with mental health problems. So we still see a lot of stigma, we still see the fact that people are forgotten and languishing in institutions. Hopefully we can shed some light. This report will help to shed some light on the human rights challenges that we continue to face, and that our mental health systems need to continue to develop. So there are very few countries that would say that they have a good solution, that they have managed to close all their institutions, that they, and I think, as Julie says, that pressure on budgets to actually think about economies of scale does sometimes tend to push people back to thinking in institutional responses, because there is this belief that somehow that must be cheaper. But actually, in terms of quality of life for citizens, in terms of the ability for people to be contributing members of society, it totally denies them that ability. So the strong feature of this report is that it's about real people. So we've been able to introduce the voices of real people. We've been able to bring forward some of their narrative and their experience of living in psychiatric and other types of institutions across Europe. And I think that's very important. So often research is about the numbers, the quantitative sort of aspects, but those qualitative aspects, those things about people's lived experience, are also equally important. And I think we need to give more prominence to hearing the voices of people's lived experience. And we see from the report that a lot of people are denied choice in their life. They're denied control over their lives. They're subject sometimes to very questionable practices. There are community services. They are almost the opposite of institutional services. And good community-based services will offer people some opportunity to lead meaningful and fulfilling lives in the community. But sometimes we need to be clear that those services are properly resourced, properly supported, and properly understood within communities. So we know that across Europe there are emerging trends in terms of some of the community resources available. There are various networks of organisations across Europe where we begin to exchange knowledge and practice. And that's very important, that people continue to talk to one another. But we also show that hundreds of thousands of people are denied their rights and that they're living without legal capacity. And that's in contravention of the United Nations Convention on the Rights of Persons with Disabilities, the CRPD, the UN CRPD. And this means that they're denied choices in terms of everyday life. So sometimes they can't make decisions like they don't have the right to vote, or to marry, or to raise their children, even to have a bank account, or to be able to go shopping, and things like that. And that really needs to change, and we must see some reform of legal systems across Europe to begin to help people to make supported decisions, and not just to have substitute decisions made for them. I think the other things that we would like to highlight is that we still see a lot of coercion, restraint and seclusion within mental health systems across Europe. And the UNCRPD has called for an end to this, and we would certainly support that. And I think we have to see a shift in practices from sometimes coercion, restraint, seclusion being seen as the norm to actually being seen as an exceptional form of treatment or care, if that's the right word. So forced treatment really is something that is not well understood. It's not always recorded. It's not always monitored in many European countries. So it's sometimes difficult to get a true and accurate picture of what's happening there. I think for me personally, as someone who runs an organisation that delivers community services, we see an absence of hope in a lot of these institutional settings. And you could almost describe systems as being hopeless. Not necessarily useless, they provide a function, but they certainly take hope out of people's lives. And in my own organisation, we talk very much about hope as being an acronym for 4 things that we think are very important for people. So that's having a home, having opportunity to participate in meaningful activity, having people in your life who aren't just paid to be there, but people as friends, as supporters, and being empowered to be involved in your own decision making. And these are the things that are often missing in institutions. They have no part in any decisions. They simply live a fairly meaningless life day to day. There's no future, there's no choice, there's no hope. Julie highlighted the lack of data, and I think how we collect data on some of these issues is very important. I even know that the bit of work I did around this, it was quite difficult to access data on all aspects, and particularly on the communities options that are available to people. We seem to be across Europe not monitoring that, not collecting data, and certainly data is not collected in a standardized form because we had to work amongst many systems in terms of how data was collected. So sometimes there's general data about numbers of people in hospital, but not specifically about which particular groups of people, whether it's dementia, learning disabilities, mental health, and so on. And sometimes it's just based on age groups as well. So I think there's a lot of work to do in helping us understand better the systems that we do have if we were to have some standard data sets. Fairly simple ones on one level would actually be a good starting point. And that information should really be very easily and available and transparent for the public to see. EU funds obviously play an important part in this whole picture, and we know that structural funds have in the past been used to rebuild institutions in some parts of Central and Eastern Europe. We hope that that's less the case now, but again, I think we need to see clear monitoring of some of the use of those funds. But this whole notion of institutions and institutionalization is not just a Central and Eastern European problem, it's across Europe, absolutely across Europe. And I think often policymakers, because the voices of people with mental health problems are not as well heard as others, it's easier sometimes for them to make decisions like, well, let's just build another institution. Let's just put people together. It'll be cheaper. No, it's not. It's certainly not better for the lives of those people. So I think in the next EU budget, we would like to see a framework that would allow investment in the transition to community-based services, not just in Central and Eastern Europe, but across Europe. That actually the structural funds are used in a very purposeful, meaningful way that actually makes that transformation. And that transformation isn't just about bringing down the walls of the institutions, it's also about changing the mindsets of the policymakers, the practitioners, and the other people involved in delivering those institutions. So institutions don't just exist within walls, they are also within people's minds as well. The EU is bound by the UNCRPD, and again, we know that they were reviewed in the UNCRPD committee reviewed the EU in 2015, and there were numerous recommendations in terms of how the EU could play a bigger part. And obviously it's up to member states to actually move forward in terms of some of their policies on this, but I think the EU can help bring together, share knowledge, research, and actually empower those countries to make some of the right decisions in terms of moving to a position where they're more compliant with the UNCRPD. So in conclusion, I hope that this report from University of Kent and from Mental Health Europe offers a bit of a wake-up call to our governments, to our policymakers, and to our people, that we actually need to invest in transforming some of our mental health systems, and that we need to hear from the people with their own lived experiences, and that we respect people's human rights, and that actually has some true meaning, not just policy rhetoric, but actually we put that into action. And that our services are based on a person-centred, recovery-focused, supportive and community-based model, rather than simply an institutional model. Thank you.
Good morning. My name is Denis Puras. I am professor of child psychiatry and public mental health at Vilnius University, Lithuania. And since 2014, I am a special rapporteur on the right to physical and mental health, appointed by UN Human Rights Council. My role in Mapping Exclusion project was that I was asked to write the foreword, but also to provide information for Lithuanian country report. As an independent expert, I can say that this report has a huge added value. It is unique in its ambition and its aim, and it looked at mental health systems not just from health but also from human rights perspective, which is extremely important. And I agree with Nigel that this report is a wake-up call. The study is proof of what I have discovered during my experience as mental health professional, and now during the last 3 years when I have a global right to health mandate. European region has good opportunities to be a global leader in this field, and there are many good initiatives in the region. However, despite many efforts and good practices, still there are many outdated, still Europe remains dependent on outdated practices such as especially institutionalization and over excessive medicalization. So institutionalization is a violation of human rights itself, but can also lead to other abuses such as violence, exploitation, even torture. I would like to address some specific issues such as coercion, role of psychiatry, status quo in policies, and voices of people with experience. So coercion, there are many misunderstandings in general public, and public remains often mystified about what is happening inside psychiatric institutions. The new focus of the report on coercive measures such as forced placement, forced treatment, restraint, seclusion, draws attention to this key issue of coercion, which has remained in the shadows so far. Then comes the role of psychiatry. In my work on mental health at UN level, including my last year report to Human Rights Council, I have stressed the role of psychiatry, also other professional groups, but especially psychiatry, which is most powerful and most influential group, and the responsibility of psychiatry to play a role in ending institutionalization, over-medicalization, coercion in psychiatry. Psychiatry, I think, needs to learn lessons of painful past and to seriously address violations of human rights that are often made in the name of medicine and psychiatry. Then status quo in mental health policies and services. The current status quo, where coercive measures and institutions which should be exceptional, they still remain as mainstream. And so the status quo does not work. It paves the way for massive and systemic violations of human rights of users of mental health services. And these types of services are detrimental to the health and quality of life of people with mental health problems. Voices of people with experience. I think it's especially strong feature of this report that it places the voices of users into the center as it should be. Because these people who have used services, they are real experts, and we have to understand and to send this message to those who make decisions. The stories in the report, the stories of people who were using services and are using, reading the stories of these individuals who report feeling traumatized, isolated and let down by coercive practices, gives a unique insight into what it is like to be on the receiving end of such services, such measures. And it will help readers to understand better the experience, the exclusion and stigma that people with lived experience face. And I am happy to be here today with Sabrina. Sabrina's contribution you will hear. I'm glad that Sabrina Palumbo is here, and she will share her experience that you might better understand how this experience can come about and what it can do to a person to be hospitalized and restrained against your will. CRPD, the shortened version of Convention on the Rights of Persons with Disabilities, should be implemented fully by European countries. It's a unique convention. It gives a lot of opportunities, and then I should use the word optimism. There are many reasons to be optimistic and hope for a better future, because in this report we can see many promising practices, many good changes in legislation, pilot programs, new systems of support, but these promising practices should not any longer be considered as alternatives and they should be placed at the center by policymakers, in the center of mental health systems, and coercive services and institutional care, they should be considered as unacceptable alternatives that need to be abandoned. So this is about this shift which is needed. Last but not least is about EU funds. Yes, they have been not responsible. They have been used in some countries not responsible way, through renovating large institutions, for example. So they need to be used for real transition to community-based services which respect human rights of people with mental health problems. And without such bold commitment from the EU and member states, it may happen that the same pattern of ineffective investment may continue. So the report is also sends some warning about this. who should read the report? Everyone who is concerned, starting from policymakers, ministers of health and other ministers, but also mental health professionals, family members, everyone who is interested in this important issue. And to conclude, the status quo is not good enough. In Europe, we can and should do better to ensure that mental health services are user-friendly, that they're centered around people and their recovery, and that they fully respect human rights of these people. And this report contributes to that future by showing what needs to change. Thank you.
Thank you.
So I'm Mariana Paraskeva. I am Greek and I'm working in the European Commission in the service that is coordinating the European Social Fund, which is one of the structural funds that have been supporting the transition from residential institutional care to community-based care services. And have my own experience, in fact, because when I was 15, in 1972, I was hospitalized because I was weighing 35 kilos. And I stayed in the hospital for 1 year, where I was force-fed, heavily sedated, and I still remember having this tube going from my nose down my stomach as a threat if I stopped eating or wanting to take the medication. I was not allowed to see my parents or anybody else. And on top of that, I had a full medical corps over me because for my, let's say, bad luck, my mother at the time was Director General of Public Health in Greece, and everybody saw me as an experiment. Anyway, I survived, but then I also happened to have a son who is autistic. He has the Asperger's syndrome. So through him as well, I'm living what he lives. And it is unacceptable, for example, that in Belgium, in Wallonia, there are only 2 mainstream schools. And this morning I was listening on the news that they were celebrating for the opening of a new school for specialized support to children with autism here in Schaerbeek. And I think that's where we come. We should stop supporting this type of activities. And we have created internally a group of parents of children with disabilities, and I keep telling parents who come to me for, let's say, ideas and support, stop trying to get your children in specialized institutions. What you should aim is to get them into mainstream schools with support. But that is the message that we need to go throughout for other people. First of all, I have to say that I was very happy to see the title of the report, Mapping and Understanding Exclusion, because mental health issues are basically and primarily issues related to exclusion of the people and the stigma that it relates, because in fact, I do consider that disability is much easier to tackle, while these mental health issues are, first of all, issues that in many, let's say, countries, like in Greece, for example, continue to be an issue that should be hidden. And this is where I say, when it was referred earlier by Mr. Henderson, that institutions are not only in the big institutions, it's also at home. You can still live at home with your family, with your parents, and still be in an institutionalized setup. In any case, we started working, in fact, on this topic, in particular through the accession of the new member states in 2004, where it was considered to be a serious problem. And the work took up, it was further enhanced with the creation of the expert group on deinstitutionalization, the so-called EEG, that was put in place by our Commissioner Spidla in 2008-2009. And for me, it was also a great experience to be able to see that there was a common goal from a number of institutions, of NGOs, that each one had its own identity, its own clientele, but they all were working towards a common goal. And that was the goal of the deinstitutionalization, that it's a term that we don't want to continue using. We are going more for dignity and independent living. That will be our motto for the next programming period of the funds. So work step up. As you know, with the expert group, we produced a toolkit and guidelines for the use of the structural funds in the period 2014-2020. And we are going to take forward the message for the next years to come. A major achievement also in relation to this area was the so-called ex-ante conditionality that we imposed in this programming period. What this means is that in all member states where there is an issue with institutional residential care, there should be a specific provision in their plan for combating exclusion about dismantling the residential, the institutional care, and establishing community-based care services. And what we would like to see in the next programming period is to have this principle applied to all member states, because as it was mentioned, this is an issue that is related to all countries, not only in the so-called new member states. That is the first thing that we aim to, and the second one is to have a specific investment priority on this topic, on deinstitutionalization, because in this way we can, first of all, have data, and then we can monitor better what is going on, which are the two shortcomings. And so far, but this is still, perhaps not off the record, but it's still in preparation. We are preparing the new legislative framework, and we hope that our proposal for the European Social Fund regulation, which contains such an investment priority, specific investment priority, will go forward, as well as our wish to have these ex-ante conditionalities imposed to all member states. So this is, in a few words, what we are doing. But for us, it is an issue that it's on top of the agenda. And additionally, we do consider that exchange of experience and good, but also bad practice to some cases, in order to learn from our mistakes, should be further enhanced. And also the awareness raising about the issue of mental health, in order to somehow decrease the feeling that a person with a mental health problem is a person that should remain alone and excluded from the society, because this is also a very, very important topic that we need to address.
Thank you.
So before I start, I would like to apologize because I didn't speak English for a long time, so please don't hesitate to interrupt me if everything I say is not clear enough. I would also like to thank the organizers for their invitation for me to share my personal experience. I have shared my testimony as part of the study on Mapping and Understanding Exclusion, but did not know that it would lead me to be here today to speak in front of you. My name is Sabrina Palumbo from France. I'm 36 years old. I suffered from anorexia, bulimia from my 17 to 30 years. I started with a diet that followed while I practiced athletics at national level. I published a first book in 2014 about my chaotic journey, including several hospitalizations and a long recovery after 1 year of involuntary placement. This period dates back to 2006-2007. This long confinement has nothing to do with classic treatment of anorexia. Anorexia does not always lead to extreme situations, as in my case. On the other hand, my story is quite revealing about the problems that we can meet in mental health care. Coming back to my experience of forced hospitalization, I was hospitalized in the general psychiatry department at Issy Les Moulineaux, where things did not go so well, and the doctors contracted my parents, saying that I was not manageable and thus in danger. To give an example, the fact that the mealtime were very difficult, and that I left the hospital without authorization just to have a coffee, led the medical services to put in my record that I was at risk of danger, of escaping and of acting out. I was then transferred to the Paul Guéraud Psychiatric Hospital, close to Paris, at the request of the doctors sorry, and of my father. It is important to note that if my father had not signed for it, the doctors intended to ask the relevant authorities for forced hospitalization. I was weighing between 30 and 35 kilos. Later, during my hospitalization, I lost even more in weight, and at 27 kilos, I was really in danger. So that's why I was saved by force. Looking back, I think that when I was forcibly hospitalized in early summer 2006, this was because I was considered as a sideshow, and even because my weight was very low. However, I had never thought of taking my own life. Those ideas came after the hospitalization that saved me. So how was it at the hospital? I was the only patient with anorexia in the ward, and I did not adhere to treatment. Actually, I did not really understand what I was doing there, and I was in denial. This led to adding further restrictions on me at the end of the summer, and the psychiatrist in charge put me in pyjamas and locked me in a so-called observation room. The psychiatrist in charge, with isolation measures. This was a room of a few square meters with a big metal curtain that the nurses lift. Okay. From time to time to observe me a little bit like a cage animal. I remained there until the end of my admission. Occasionally I was restrained as well, because the nurses put a nasogastric tube, which I ripped off at first because I did not want it. Therefore, to stop me from ripping the tube away, they attached me to the bed. During several months, I had no personal hygiene. I did not have the right to see my family, my dear ones. I had no access even to the toilet, but had to have a chamber pot. If I had more time, I could tell you a lot about what I saw, heard, and experienced. I could tell you about when 4 or 5 people came into my room kept me by force in bed and forcibly attached the nasogastric tube before leaving without almost saying a word. I could tell you about the time when the nurse dragged me by the hair in the hallway after a blood test because I did not go back to the observation room fast enough. I could speak about many unreal scenes which are difficult to talk about. What I prefer to tell you is about what I denounced. I have filed an appeal against the hospital for inhuman and degrading treatment. The goal is not so much to help myself to fully heal, but more to prevent a similar case again to anyone else. If I testify, it's because I am convinced that there is much better way to do things than to isolate a person with anorexia within 4 walls, to tie him or her up and to forcibly feed him or her to prevent him or her from dying. Whatever will be the outcome of this process, what is important to me to say is that patients also have rights and have the right to speak out and be heard. They obviously have the right to be respected and properly informed and be a part of the decision making about their own life and hers. What I deplore is the banalization in France of the so-called last resort methods, such as isolation and restraint, which should really be used as a last method and only under very strict and properly controlled conditions. I do understand that the hard methods have saved my life, but at what price? When I came out of the hospital, I was nothing. I was recovered in the eyes of people just because I have gained some weight, but I had lost trust in the health care, and still today, 10 years later, I have a scar on my wrist, and I can describe the bars on the window of my observation room and the cracks in the ceiling. If I have to summarize anorexia, it's everything except just a weight problem. I create an association to help people suffer from eating disorders. For me, it's more a problem of connections. In other words, depriving an anorexic person of the presence of human warmth is certainly not helping him or her to get better. So my testimony is an invitation to challenge the current healthcare system and calls for a paradigm shift towards more user participation and cooperation between caregivers and care receivers. What I expect from the report presented today is that it will provide a more accurate view of the reality and help raise awareness. Finally, eating disorders is a form of survival rather than a desire to die. Still, it takes 15,000 lives in France every year, although many do recover, and it's important to stress. I believe it may have been harder for me to heal from the trauma of the hospitalization, first of hospitalization, rather than from anorexia itself. Thank you.
Thank you.
Thank you.
So, thank you.